Good morning, everyone. I'm Dr. Tara Kieran. I'm a family physician at St. Michael's Hospital and the Vice Chair for Quality and Innovation at our Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions together with the Ontario College of Family Physicians. And I'm turning it over to the OCFP President, Mekalai Kumanan, to introduce the session. Mekalai?
Good morning, everyone, and thank you, Tara. I'm really pleased to be here and have all of you here with us. We have a really good session lined up for you today. And just a remainer that this is a main pro accredited session. Details will be sent to you after the session. Next slide. Okay, so I'd like to just say our land acknowledgement. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Neutral peoples. Next slide, please. So I just wanted to take a moment for a reflection. This is a story about a Cree man named George Matches from northern Quebec. So his story is that he was in the hospital in Montreal for surgery and wasn't eating for quite some time when he was post-op, which was quite a concern for his care team. And just before being discharged, he disclosed to a medical student that the reason he wasn't eating was because the hospital food reminded him of the food that he was given in residential school. So George has since passed away, but his feedback ultimately prompted change within the hospital. And within a year, they added bannock to their menu, so traditional bread. And I wanted to just illustrate this story because I think it's just really important for us to ensure that everything we're doing is reflective of culturally safe practices. And I want us to always remember to reflect on the care that we're providing and ensure that we are doing our best to try to understand a patient's history and how it affects the way they receive care. So just a reminder that sometimes small things can make a big difference and have quite a significant impact. Next slide.
Thanks so much, Mekalai. As you know, the sessions that we hold, they're part of a series, and you can view past sessions at the website link that's on the slide. Importantly, our conversation today is going to be building on our last two conversations where we had Dr. Alison McGeer last time, for example, who spoke about the bivalent vaccines in more detail. So they're going to be, we'll be building on those conversations, but if you ever want to reference them, you can go to our past session, and shout out to our planning committee who continues to bring you these sessions. Next slide. I'm excited to introduce our panelists today. Next slide. And delighted to have our co-hosts. So I'm going to start with Dr. Janine McCready.
Good morning, everyone. So my name is Janine McCready. I'm one of the infectious disease physicians at Garron Hospital in East Toronto. And I'm, in addition to infectious diseases consultations, I do infection control and antimicrobial stewardship. And I've had the opportunity to be pretty involved with our schools in East Toronto, kind of supporting them through COVID and now supporting them through all of the influenza-like illness and respiratory infections that they're all struggling through at the current time. Thanks for having me.
Thanks, Janine. Rosemarie?
Good morning, everyone. Rosemarie Lall. I'm a family doctor practicing in Scarborough. I'm our FO lead. I'm also the local site at Scarborough's Teaching Center for Family Physicians, and I am the research lead there. Thank you.
Liz? Is Liz there yet? I think she's having some trouble connecting. Maybe we'll go to the next slide. Mekalai?
Good morning, everyone. My name is Mekalai Kumanan. I'm the president of the Ontario College of Family Physicians, and I practice in Cambridge. I do receive a stipend for my role and have been part of the ECHO Chronic Pain and Rheumatology Advisory Board, which does not pose a conflict for today.
and I'm Tara Kieran, and I've just listed some salary support research grants I've received and speakers honoraria, none of which I think pose a conflict for today. Next slide. So as usual, what makes these sessions dynamic and interesting, I think, are the questions that you put to the panelists. And I just ask if you can put your questions into the Q&A and then use the chat to share your resources, the tips, connect with other people. We always love hearing from you and what you're doing in your practice. And we always learn from the resources that you share. Next slide. So without further ado, I'm going to turn it over next to Dr. Janine McCready. Next slide.
Thank you so much, Tara. Okay, so just to kind of see where we're at, there's lots of things circulating right now. In terms of COVID-19, unfortunately, there still is a lot circulating in the community, and risk of transmission, if people are out there in indoor spaces without masks, is very high. This was the wastewater signal from a week ago, so from the 20th. Yesterday, late in the day, they released some new, which the peak is, or the trajectory of that incline is not as steep, but it still is on the rise. And a lot of that is driven right now by increases in the GTA and also in Central East. We do expect to see further increases as the weather gets colder, as more people go inside, and as we see some new variants, and your immunity from previous vaccines continues to wane, as many people have only had 3 doses, as of last January. So their immunity is waning. Next slide. So this is based on hospital admissions just for COVID at this point. So you can see in the under 4, this was as of the 15th. So there was about 17 children admitted as of the 15th of October. The majority of those were all under 5 and unvaccinated. So sadly, in the province to date, only about 6.5% of kids under 5 have had 1 dose of vaccine. So that's an important area. If you guys have children in that age group in your practice, and the parents are asking you about vaccine, it's a really important place to have a conversation and really encourage vaccine, even if they've had previous COVID infection, because we know from most of the studies that hybrid immunity is quite much better and more protective. So if a child is more than 2 months out from a previous infection, useful to get that first dose of vaccine. And we know that the vaccines in that age group are safe and effective. So really can use everyone's help, because the 6.5% vaccinated in that age group is pretty abysmal, and we are seeing admissions and expect to see more over the winter. And from hearing from our colleagues at the PEDS hospitals, the majority of those are admitted for COVID, not as an incidental. And then the group with the highest admissions is in the over 80s, and then in the 60 to 70 category. Many of those that we're seeing are frail, older adults, that they're not coming in with necessarily COVID pneumonia like we used to see, but they are still, they're falling, or they're having exacerbations of their CHF or their COPD, and it's leading to long admissions, which is putting obviously a huge strain on them and their health, and then on the system as well. Next slide. So this is just to give us a sense of what all the variants out there and what could be coming. So lots of different information here. Right now, most of what we're seeing is BA5. From looking at growth advantage in Canada and then across the world, and some very smart people at PHO are looking at these and monitoring it. The variant kind of to keep the most eye on is BQ11, and then globally, the other one is that we're seeing is XBB1 right at the end, where those seem to have a bigger growth advantage over BA5. So meaning that for every infection we would see from BA5, you'd see an increased transmissibility and increased infections from these other variants. So at this point, BQ11 is the one that's increasing the most in Canada, and why do we care? What's so different about these things? Anytime we see a new variant that's kind of escaping immunity and increasing over the previous one, we do worry about increased transmissibility. Are they to escape immunity from vaccines and from prior infection? And we still are learning about these things, and we'll look to other places in the world where these variants have already started to increase. France has a larger proportion of BQ11, and it looks like they're starting to peak, so that might be encouraging, but really time will tell. And the main thing that we can do to overcome any of these things is to use masks, when you're in indoor settings, and also to get the bivalent booster, because that's going to, even if it's not perfect, it's going to provide some protection against these things. Next slide. So just to, we aren't just dealing with COVID. There are lots of other viruses circulating. This is our outlook of across the province of influenza. So influenza A is the line in orange there, and it certainly is starting to increase. Only about 2.2% of tests were positive for influenza this last week, but certainly increasing and higher than what we've seen obviously in previous years at this time due to control measures. But even from a few years previously, it is increasing a little bit earlier than we would have seen. And looking at what happened in Australia and New Zealand last year for what we kind of used to predict our season, they had a very large and early peak. So we do expect this to kind of increase as fairly rapidly in the fall. So it's a good time to get a flu shot. A lot of people ask, oh, should I wait till later? Last year we saw kind of a later peak in May, but if people are asking, get a flu shot, that's the best protection you can have. And then again, masks will protect you indoors especially in crowded areas from flu as well as influenza. So there's not huge levels right now, but we are certainly seeing some people admitted to hospital as well. Next slide. And then this is just giving us an outlook across Canada about other viruses. So we've heard a lot about in the media in the last few days about RSV and the surge of admissions and presentations in kids. RSV levels are here in yellow, so they are increasing. Here in Ontario, it's actually only about 2.1% positivity of tests, so actually still fairly low, but it is already causing a strain on the system. And across Canada, I think it's about 3.2%. So the largest share of viruses right now is kind of moderate activity with enterovirus and rhinovirus. And then you have the RSV, and then at the top, influenza. So this doesn't include COVID here. So steady increase, and we're just at the start of this season, and it's already causing a big strain on the system. And we do expect that it will continue to increase in the coming weeks. I think the thing that's really been driven home and really sobering for us here is that we are, obviously we're seeing a ton of people coming to the emergency department, and some of those need to come, and some of them, could probably be managed outside of the emergency department with other supports and with help from all of you. And the thing that really does scare me is that unfortunately, more of those people that are coming to hospital, especially the children, are actually converting to admissions. And so even in our hospital here, we have a small footprint for pediatric beds. We usually only have 8 admitted beds, but we're actually trying to double that and double up the children, so that instead of, we've only ever had 1 child in each room, and now we're trying to actually increase it to 2, and we're trying to train adult nurses to be able to care for the kids, because there's such a strain on the system. Because the across the system, and here in Toronto, their sick kids is at 100% capacity with their surge beds opened. And so there's nowhere to transfer the kids that are really sick. And so unless they're very sick and they need to go to a tertiary care center, we're it. And so that's happening right across the province. And I know the emergency rooms everywhere are totally overwhelmed, and that's resulting in the inpatient being overwhelmed too. So it's going to be a rough season, and that's why we're here talking about this, to see how we can get all hands on deck and enlist all of your support to keep those kids as healthy as possible, and then to keep them out of the emergency departments if possible. Next slide. Okay, so now that we're talking about that, kids coming or people coming to your office, little review of infection control in an office setting. So the very helpful and what really ideally everyone should be doing is universal masking. So obviously it's become a bit of a challenge with the province, dropping mandatory masking outside of most settings or in most settings, but really that's your, a huge prevention strategy. So obviously all the staff wearing masks, the patients wearing masks as long as they're physically able to. And in terms of PPE, for any encounter where the person has a respiratory tract illness, a suspected COVID or suspected influenza-like illness, ideally you should be wearing the mask as well as the face shield. In terms of if it is suspected COVID, ideally a fit tested N95 mask. But if you see someone and and afterwards, in retrospect, you realize they have a respiratory tract infection and you're wearing a surgical mask, plus or minus a face shield, the risk is still very low. In hospital, we've had thousands of patient hours now where we've cared for patients with COVID, or people have ended up having COVID, and the risk to staff, as long as people are wearing at least the surgical mask plus or minus the face shield, is extremely low. Obviously, ideally, you should wear that N95 if you know, but that I wouldn't be overly anxious if you've seen people wearing your surgical mask and afterwards you find out they actually have an COVID infection. And then in terms of the main thing is really that mask. And then in terms of the face shield, ideally, or the eye protection, ideally wear it if you know that they have a respiratory tract infection. And glove and gowns, again, same thing. If you know that they have a respiratory tract infection, ideally would wear the glove and gowns. But most of these infections, if you are wearing the mask and you wash your hands before and after you've seen them, the risk that you're going to transmit to yourself or get the infection without wearing a glove and gowns is exceedingly low. So I wouldn't be, again, overly stressed if you forget or you don't have that ability to have a glove and gown on every single encounter with patients. Important hand hygiene. So having alcohol-based hand rub available throughout your office for patients to use, for your staff to use, and obviously for you to use before and after patient care. Environmental cleaning, really kind of gone back to what we were doing routinely pre-COVID. So high-touch surfaces being done once a day, and then after patient care, routinely cleaning the surfaces that patients have touched before seeing the next patient in that room, but not having to do terminal cleans of every area. Ventilation, I'm sure we could do a whole talk on ventilation, and I think I was on one when Dr. Jaya Nataraja did one about a year ago, but really trying to do everything you can to improve that ventilation in your office. So if you can open windows, checking with your building if they've had new filters and if they can do that. And if you don't have the ability to open windows and have fresh air circulating, then using HEPA filters if possible. In terms of the waiting rooms, ideally, if people have respiratory tract infections and you're bringing in them to see them, ideally would be moving those into a room right away if you have that space, so that they're not sitting in a waiting room, or having them wait outside and then calling them in and bringing them right to a room. If they are within the office, obviously making sure that they're wearing a mask and they're trying to sit separately from other individuals waiting, so you're not having the 80-year-old sitting next to the 3-year-old with the runny nose and the cough. Physical distancing in the waiting room is still recommended, but obviously not feasible in all cases and depending on your setting. So not mandatory, but again, if you have people that are wearing masks and they're well and they're sitting closer together, that's much lower risk than if they're not masking properly and they have viral illnesses and they're sitting side by side. So trying to reduce the risk as much as possible. In terms of screening, there's been, I think some of the comments that we've seen are people are screened when they book the appointment and then when they come in for the appointment on the day of. If you're booking appointments, 2, 3, 4 weeks in advance, screening them at that time for a respiratory tract infection isn't really going to change anything or be particularly helpful. So it's more important to just reinforce to them, tell us if you have symptoms when you do come in for the visit, and then screening them on the day of. But not a reason to not see them. So if they need to be seen for another reason and they end up having, a bit of a runny nose on the day of visit, you don't need to cancel the visit, right? Wear a mask and as we said, keep them separate from the other patients if you can, but still important to see those people because it just creates a cascade. If we're delaying care and then, other people they're going to end up coming to the emergency department or being seen elsewhere if they don't get that routine care. And then we'll talk, I think, in a minute just about if they are actually sick from a respiratory infection, when it's important to see them. And then the other thing is, outbreaks within your staff. So trying as much as we all want to get back to being social and enjoying, that social environment of being at work, trying to minimize outbreaks within your staff. So not having people congregate without masks in the break room. So having people stagger when they're eating, and if they do have to eat together, trying to minimize time when they have their masks off at the same time, because you don't want to be without all of your support staff or all of your doctors or your nurses all at the same time. So that's an important consideration as well. Next slide. So managing influenza-like illness. So, you know, we've been kind of, for the last couple of years, a lot of it's been, okay, well, we can't see these people, but now we really need to see these people because there's all kinds of things circulating. It's not all COVID. And so really important to help tease out, well, who needs to go to the emerge, who needs to be seen, and who can stay home. And I'm not going to pretend this is an easy answer. And I know Dr. Lall is going to speak to this as well. But I think some main points when I think about this and think about who it's important for you guys to see and who we're seeing in the emergency department. So who needs to go to the emergency department? And I think, you know, most of you would know this. If someone is presenting with and are calling in and they have severe symptoms, so they're having difficulty breathing, you know, they're speaking one-word sentences, you can tell that they're wheezing or they're unwell, they're having severe chest pain or altered level of consciousness, they go to the emerge. If they're infants under 3 months with a fever, difficulty breathing, or they're unwell, again, they should be assessed. And then if they're children, and this, you know, if they're children that are over 3 months, but they've had a fever for more than 7 days, they have difficulty breathing, they're dehydrated, they're not waking up, you know, you're worried about things like meningitis or more prolonged. If a fever for 7 days, some of you may be able to, you know, assess them if they're well, but they need some kind of expedited workup. So if you're not comfortable, you know, doing an expedited workup for those kids and seeing them right away, then those ones should be assessed as well. But who needs to be seen, you know, by yourself, right? Who should be seen in clinic, ideally? So if someone comes in or calls in and they have a fever, which is an unclear etiology, you know, those people can definitely be seen in clinic and really, you know, really should be, because it could be many things. And a fever right now, it could be flu, it could be COVID, it could be a UTI, it could be otitis media, it could be strep throat. And an assessment is so important to help differentiate that. And I've even seen people that are referred to us with fever of unknown origin that haven't had an exam by, you know, that they've seen multiple people and no one's had an exam and no one's had blood cultures. And you guys are good at that. And you're good at looking at someone and knowing, are they sick? And do we need to worry? Or you know, can we wait on this and monitor? So really, I think fever NYD with no specific respiratory symptoms that you can clearly point to, I think is an important one to assess, especially children, because we know a lot of parents are very anxious right now. So if they don't get assessed, they don't get seen, they don't get reassured, they're going to come to emerge with their kids with the fever. And then anyone that's higher risk. So if you have children under 2, adults over 65, they have a lot of comorbidities, they're immunosuppressed or they're pregnant, you don't always have to necessarily see those people in person if they sound like they're well and they're, you know, they're able to give you a good story and know when to escalate. But those people, I would definitely more err on the side of doing an assessment in person, seeing how they're doing. And then potentially, if they're older and you're worried about them, but they don't need to come to hospital, you know, using some of the resources we have across the province, like the remote care management programs, and enrolling them in those so someone can help monitor them if you have, you know, if those are available, so that people aren't left on their own and you know, and struggling regardless of what they're infected with. Next slide. And then testing and treatment. So it's a bit tougher now with COVID and everything else circulating, but in terms of who to test for COVID, so I think the main take home is anyone who you would consider treatment for. So if they're older, so over 65, or they have multiple comorbidities, those people would be important to test for COVID. Or if they're, you know, under vaccinated or unvaccinated, and really now if they've only had 2 or 3 doses and their last dose was nearly a year ago, those people, if they're older and in those risk categories, I would test them and then have a conversation about whether they would benefit from Paxlovid or an antiviral. Because treating those people, you know, it's not a magic fix, but if they are higher risk, it may keep them healthier and keep them home, keep them out of hospital. Other people to consider testing would be obviously healthcare workers, because that's important to reduce the spread. And then if you have someone who's a caregiver or a close contact for a vulnerable individual, also really useful, because people do change their behavior when they know whether or not if it's COVID or not. And it will actually allow them then to isolate safely. And then if their family member to become symptomatic, you can get them to come and get tested and access antivirals much faster, as opposed to delaying. And the important thing with Paxlovid is it has to be given within 5 days. So you really want to know early in that course if it is COVID or not, so you can initiate treatment. In terms of treatment or in terms of testing, it doesn't have to be a PCR test. If it's rat positive and they have symptoms, it's COVID, and you don't need to have a PCR to prescribe Paxlovid. If they have symptoms and they're rat positive, you can prescribe Paxlovid based on that. But if you are suspecting COVID and their rat is negative, or they have close contacts that are COVID positive and their rat is negative, that is still very likely COVID, and would recommend getting a PCR test in that case. So if the rat's positive, you can act on it if they have symptoms. But if the rat's negative, I would not hang my hat on that, and I would get a PCR. And the important thing with rats would make sure you do proper technique. So I've seen people do them where they're kind of like a drive-by. They just like swab for 2 seconds and then they put it in and they're like, oh, it's negative, or they check it for 5 minutes. You need to do really good swabs, and ideally inside of the cheek, back of the tongue or back of the throat, and then the nose as well, so that you actually get a good swab. Next slide. So really what we just talked about is trying to determine the risk of progression of severe disease. So it's a kind of a combination of the person's age, the number of vaccines, their comorbidities, are they immunosuppressed, are they pregnant, and then do you decide to treat? So this is a table from the science table. Because we're already kind of almost a year out from when people have had their 3rd vaccines, if you're in a high risk category, you're over 70, over 80, you have more than 3 risk factors, or more than 2 risk factors, or you're frail, and you've had those 3 doses, but it's been a year, those people I would even have a conversation with and see if they are interested in taking Paxlovid, because it's at this point, they are at higher risk, and we are seeing those people get admitted to hospital. And then the other important question, which we haven't had to think about in a couple of years, is Tamiflu. So when do we give Tamiflu? Who would we want to give Tamiflu to? And it's really a similar population. So over 65, under 2, or under 5, even if they're unvaccinated, people with comorbidities, and people that are immunosuppressed and pregnant. So the challenge is when you see somebody, how do you know if it's COVID or flu or RSV or human metapneumovirus? And you can't. All the symptoms are very similar. And a lot of the times, the symptoms could be all over the map. So it's kind of getting a COVID test to rule that out, because that's one thing we can test for. It's hard to get an influenza test unless people are seen, in the emergency department. We're actually trying to push and offer to public health to do a pilot here where we actually test people for influenza as well and see if we can get them treated early. So that may be something you see over the course of the winter rolled out elsewhere. But if the flu levels are high in your community, so you're hearing that our data goes up and we're seeing more flu, it's not COVID, and they're within one of those high risk categories, and they're within. So with Tamiflu, it has to be within 48 hours of symptom onset. So it's early in their course of onset, and you think they're at risk, that would be sometime when it would be reasonable to consider prescribing Tamiflu to those people. And it's not an easy thing, but if you have, a pregnant person that is early in the course of illness, rat negative, no COVID exposures, and flu is circulating, that'd be somebody I'd consider giving Tamiflu to. Or a 70-year-old person with COPD, CHF, has COVID negative, lots of flu around. They come in today and they have symptoms with fever and a supportive of flu. I'd give those people Tamiflu, because it could prevent them from ending up in hospital. Next slide. Okay, so I know that there's a lot of talk about boosters, but when do we get it? What do we do with it? So this is a nice kind of flow diagram from Public Health Ontario from Ontario Health that should help we'll just kind of walk through it quickly. So trying to make it as simple as possible. So if somebody is over 65, pregnant, I would say moderately or more immunocompromised, or a healthcare worker or an Indigenous person, and it's been more than 3 months since they last had COVID or they last had a vaccine dose, get your bivalent. Get the bivalent vaccine, encourage people to get it. It doesn't really matter which one. So there's the Moderna, which is the BA1, the Pfizer, which is the BA4/5. The new variants that are circulating are kind of offshoots of BA4, BA5. So maybe a slight preference for those, but really the Moderna is a little bit higher dose and maybe a bit more immunogenic. So whatever is available, I would get whatever's available. They're both good, important to get it for this winter. So if people are not in one of those age categories, then most of the literature, or not the literature, but most of the recommendations is kind of, has it been more than 6 months since your last vaccine or last COVID? But when I was on the NACI briefing when they introduced it, and a lot of the talk was depending on the epidemiological situation and how much COVID we're seeing. So if we're seeing lots of COVID and the person is going out, going to see lots of people in public, going on a trip, they're having lots of exposure. If they're within that 3 to 6 month window and they're interested in getting the vaccine, also fine to get it for them, right? If they're a younger male, like 18 to 30, or a younger person 18 to 30 and have no risk factors and they're not taking care of a vulnerable adult, reasonable to wait the longer to the longer interval. But if you have contact with elderly adults, or you're going to go on a trip and you're within that 3 to 6 month interval, I think it's also reasonable to give people those doses. And the NACI advice kind of encompasses that. All of the things we're learning are evolving. So this is not going to be a 3 to 6 month booster for the rest of our lives. And I know people are fatigued about that. But I think when I talk to people, it's all about getting through the next season and keeping them out of hospital and keeping their family safe for this winter. And don't try to, if they think that they're going to have to do this for the rest of their lives, they're going to give up now. So it's more getting them to do it, for now, for this winter. And then, then we talk about it the next time we have to worry about it. So really, for anyone high risk, certainly if it's been more than 3 months, get the bivalent. For anybody else that's not high risk, if they have contact with vulnerable people or other high risk behaviors, if they're within that above 3 months, fine to get it. And then for anyone else that's low risk and doesn't have high risk contacts, wait 6 months post COVID or post last vaccine. And it doesn't really matter which one; they're both good. Maybe a slight preference for the BA4, BA5 because the new variants are kind of offshoots of that, but we don't know. We don't have any data of how well it's going to cover. Hopefully that's okay. Next slide. So basically that's at the end. I mean, we've covered a lot of this and from talking through it, but the things that I would really drive home to patients would be, please get your flu shot this year. We don't know how good the match will be for the flu shot, but we expect to see a lot of flu. So, all ages, important. Encourage those bivalent boosters. And if you have children that are under 5, encourage them to get vaccinated. The only 6.5% of kids under 5 have had even one dose of the COVID vaccine, which is pretty abysmal. And then basic public health measures. We've seen, I think a lot of people, it seems people are just kind of giving up, but stay home when you're sick. It's still important to do that. And if you are going out, wear a mask, especially if you're within a few days of having symptoms. So whether it's COVID or anything, this is important, and kind of shifting people's focus so that even if they're frustrated and tired of COVID, this is about not overwhelming the entire system this winter. And encouraging masking in indoor public spaces. That's going to minimize the amount and the spread throughout, and super important. So I will stop there, and thank you.
Thanks so much, Janine. There was so much in that presentation that was important, and I think it just has spurred a flurry of dialogue among folks as well. I do want to acknowledge the great comments in the chat. I know some people are struggling with getting your patients even just to wear masks in your office. And I think that's something that the OCFP team and others on the call have heard, and I hope we'll take back to advocate for clearer rules. Unfortunately, it also means that practices do have higher costs when they're giving out masks because it's something that you can't charge for. But I do want to acknowledge that is a strain for small practices, as been mentioned in the chat. So again, I think the OCFP has noted that and are taking that counsel and your experience back. There are a lot of questions for you, and then I do also want to have Rosemarie share some of her insights too. So I'm going to take a few questions and then we'll go to Rosemarie. I think one of the questions is just around testing, and I know a specific question in the Q&A is how good are the rats at picking up Omicron, and maybe we'll start with that, but then I might follow up with a couple of other questions related to that.
Yeah, great question. I mean, I haven't seen an exact kind of percentage, but certainly it still will pick it up. It's still in the majority of cases. I think what we see is when it doesn't pick it up, it's either people don't do the test properly or they test once very early and then they don't test again. So one thing we do see when people are vaccinated is that if you have symptoms right now and you do a test, you might be negative because you're perhaps getting as much virus because your body is fighting and the viral load is actually lower and not picking it up. But if you repeat that test 2 days in or 4 days in, then it will become positive. So I think it's important to do the test properly, but also repeat it daily for probably 3-4 days. And based on we did a study here where we were looking at viral loads as people went along and vaccinated individuals, and their peak viral load was probably actually around kind of day 3 to 5, and then all the way they were still positive all the way up to day 8, day 9. But your peak viral load in vaccinated was actually more like that day 3 to 5 versus in unvaccinated. Previously they were actually probably highest at day 0, and you were shedding the 2 days before. So super important to keep testing, and then the rat is more sensitive. And if there's people in a house that are all positive, test everybody, right? Because if everybody's negative, very unlikely it's COVID. So, if one of you is positive, one of you is negative, it's probably all COVID. It's not that you have 6 different viruses in your house. So important to test, multiple people in the household and continue to test. And it should pick it up. There's nothing that's mutated about the virus that is, now escaping the ability to detect on rat. And we've seen similar things with BA5 and, the new variants that are coming.
So, related, people are asking, where can I get a PCR test now? And so I just want to flag that I believe there have been, so I wonder if someone from the OCFP team or Liz or Mekalai can just put that link into the chat in terms of where you can get the PCR test now. I know that many of us are also doing it in our offices, and so that gives you more control over it and being able to do it in a timely way. I do want to just follow up on who you said should get the PCR test, Janine. And so you mentioned, of course, older adults with the risk factors who we might want to treat. When are there times where you would want to do it for a kid? One of the things that's also tricky is, figuring out for kids what it is that they have that then seems to influence how a family might manage it.
Yeah.
And thank you, Liz, for putting that link in the chat for the PCR and where to get it.
Yeah, so in kids, the official answer from the province, is that kids aren't eligible for PCR testing, but I do think it's very useful in some situations when you're trying to tease out, what's going on. Are you also dealing with some kind of concomitant bacterial infection, or do they have flu? So, if the child comes to hospital, then we're able to do a PCR test. But if you think that it's going to change your management and whether or not they would actually end up needing to go to hospital, I would sure do a PCR test on those children, because if it's going to reduce their risk of going to hospital and it's going to help you inform your decision making, then I think it's a useful thing to do, right? If they're a well child and they have a bit of a sniffly nose, they can continue to do rats at home. But if they're more more, they're kind of borderline or they're more ill, and it's going to help you make your decisions, I think it's fine to do a PCR test. I think it also, in those situations, if you have multi-generational homes where you have older people living in those households or healthcare workers living in those households, certainly those children would be fine to do, I would recommend doing PCR tests on those children as well, because knowing if they have COVID, you can then actually try to modify how they're behaving in the household and separate the older people from the younger people, minimize transmission. Or if the older people do get COVID, you can know right away that they have it and then decide whether or not to prescribe Paxlovid. And same thing for healthcare workers, obviously important, because then they can modify their behavior when they're going to wear an N95, don't have lunch with all their colleagues and create an outbreak at work. So I think if it's going to change your management of the child, if they're more ill, especially if they're young children, I think, because if it's not COVID and it could be influenza, then you actually may think about giving them Tamiflu in that situation. So that would be important. Yeah.
So Kimberly Wintermute and Kevin Lai have also just put in the chat that you can become a sentinel physician tester for flu and I think maybe even COVID-19. And so they've put the email address if you're interested in that. So that's one way in which you are helping the health system, but also potentially helping your patients in direct patient care as well. And then others have asked where you can get that. And so I'll just ask Liz or Mekalai if you can put in the chat where to get the PCR test, basically from Public Health Ontario, where you should be able to order PCR tests to your office. I'm going to switch gears now a little bit to talk about the bivalent vaccine. So you did talk about this briefly, Janine, but I wonder if you could speak again on the 2 bivalent vaccines and which one we should be recommending. So if you could just cover that again, and then maybe you could also cover that in the context of age groups. So thinking about teens, the general adult population, and then older adults, and whether your recommendations differ by age.
Perfect. So there's 2 main bivalents right now available in Canada. There's the Moderna BA1, and it's a 50 microgram dose. And then there's the Pfizer BA4, BA5, which is 30 microgram dose. So for your 12 to 18-year-olds, the only bivalent that's available right now is the Pfizer. So if they're in that age category, they're due for a 3rd or 4th or whatever dose, it's the Pfizer for the 12 to 18-year-olds. Under 12, there is no bivalent right now. So it's just the regular booster. If you have parents that they magically, like my children, somehow never had COVID, we hadn't had a booster in more than 6 months. So I got my kid the regular booster. So if they're under 12, they would get the regular old booster, because there is not a bivalent available. We don't know the timeline on that. It's available in the United States, and last time I heard from NACI, they hadn't had it yet. So they were expecting more like December, January. So if the kids haven't had COVID and it's been more than 6 months, you could get them boosted with the regular. Above 18, so your options are either Moderna or the Pfizer BA4, BA5. Very similar. The trouble is we don't have a lot of human data on how much it's actually, boosting specifically for the Omicron strains. So both are good. I don't want to get kind of caught in the weeds. So I would really almost say, whichever one is available, get it. The Moderna, there's been some talk, and which we've seen all along with Moderna, because it's a 50 microgram dose, that potentially it's a little bit more immunogenic. So potentially for older adults, maybe that's a bit better. But I think that's offset because Pfizer is BA4, BA5. So that is what's circulating right now. And the new Omicron variants, the XB11 and the other one are offshoots of BA5. So perhaps theoretically, it will work a little bit better, but we don't know. We don't have real life data, and we won't until months from now. So I think that there's, when you're counseling people, I would say whichever is easier to get would get that. I don't think it's a big difference between the two. And new data will emerge. So if we say anything definitively, it will probably be different because that's the way it's been with COVID. But those would be the two considerations, is that, maybe the Moderna is a bit more immunogenic, but the BA4, BA5 is more matched to the current strain. And most of the time people are moving to whatever is available. A lot of places are just carrying Pfizer now because it's easy, because you can give it for anywhere 12 plus all the way up. But I wouldn't want to discourage someone if they couldn't find one to get the other one.
Thanks, Janine. There are, so I'm going to just take a couple more questions and then go to Rosemary's slide. So one, just to finish off this discussion about bivalent, maybe just quickly, can you comment on the side effect profile? Some people are saying their patients are saying they get quite sick with fever, headache for a few days, more severe and longer than the previous vaccine. Has that been shown in the trials?
So it was fairly similar in the trials. The Moderna, it was only there. The Moderna generally, there's always slightly more side effects because it's a bigger dose. But I'd have to look at it again, but I don't recall it was like lasting several days. It was more just the more immediate kind of 24 hours. Anecdotally, a lot of people say they have more side effects from the Moderna than they do from the Pfizer because it's a bit of a bigger boost. But no, again, I wouldn't avoid one or the other based on that. If people are really worried about that, maybe that's a reason for that person to take Pfizer as opposed to Moderna, if that's their concern.
Thanks, Janine. And so one question, the last question, and then one comment. And so from Benent Lamb, it says, if a high-risk patient has only very mild respiratory symptoms, for example, no fever, no shortness of breath, fully alert, they just have a bit of a sore throat. However, they are rat positive for COVID. Would you give this person Paxlovid?
Yeah, so it's a great question. So I think it depends what you mean by high risk. So if they're immunocompromised in some way, so that you don't think the vaccines would have worked, they're a transplant patient, or, well, that's tricky because it interacts, but say that they're on a significant amount of immunosuppression, say they're on rituximab, that person I still would recommend Paxlovid to if they're early, because what we saw with COVID pneumonia, and we don't thankfully see it very often anymore, is that you may feel not unreasonable for the first several days. And then around day 7 to 10, that's when you get worse and you have the COVID pneumonia. And we actually had a horrible death in a patient similar to that, where up front they felt okay. So they didn't get any antivirals, and then they came in late, and then it was too late. So if their immune system is not normal, and so they wouldn't have responded to the vaccines, those people I would still treat with Paxlovid or remdesivir if you have interactions. If it's somebody who, say they're 75, they've had 4 doses of vaccine, they have multiple comorbidities, but they have minor symptoms, and they have potentially, may or may not have drug interactions, those people I would be comfortable just monitoring, because their immune system should still be good enough to mount a response. And it would be very rare to see those people progress late, because they should have had a response to the vaccine and they've adequately vaccinated. The risk of the interactions from the Paxlovid and the side effects from it may be similar to any benefit that they're going to get from it. So it kind of depends on what you mean by high risk. If they're adequately vaccinated and they have comorbidities and they have mild symptoms, those people I would have a conversation with and I wouldn't treat. And I'd probably check in with them. Say it was day 2, I'd probably check in with them again day 4 and just say, hey, how are you feeling? Are your symptoms worse? If they're better, I wouldn't treat. If they're worse, maybe treat at that point. But if they're immunocompromised and the vaccine, you wouldn't have expected the vaccine to work, then I would consider treating them. And if they're unvaccinated, and they haven't had COVID before, then I would still recommend treatment for them if they're above 60, because those people would still be higher risk regardless of their symptoms early on.
Thanks, Janine. So I'm going to ask Olivia, can you please bring up Rosemary's slides? As Rosemary's slides are coming up, I just want to just speak to a couple of things. One is, I think Hal Braden has quite recently asked, can we not ask the Chief Medical Officer of Health to mandate masks indoors again? It certainly looks like the healthcare system is in crisis. And I think how many of us would agree with you. And certainly I think we can all use our voices to support that call. And as we know, masks help not just for COVID, but for many of those other viruses or all of those other viruses that Janine talked about as well. I also do want to thank our OMA colleagues who've put together some terrific resources that can support people. So I think Natalie and her team have posted in the chat a new vaccine resource that helps to guide people which vaccine to choose or which has been approved in what circumstance, et cetera. And it's a physician-oriented resource. And then there's also a great resource that they've posted around to support you doing PCR testing in the office. So we will, just as a reminder, collate all of the resources as well as including some of the great information that Kevin Lai and others have put in the chat about becoming a sentinel tester and what that means. So we will circulate those resources in case it's too difficult to kind of extract that from this very busy and wonderful chat. So I will turn it over though to you now, Rosemarie, and you're going to give us a little bit of a picture on the ground that I think I'm getting already from many of the comments in the chat, but I think you're going to be able to go into it a little bit more deeply. So Rosemarie, over to you.
Tara, thank you so much. And thank you for this opportunity just to highlight what's happening in the community offices. This presentation is not just based on my experience, but also from experiences from my Scarborough colleagues who graciously responded to my plea of, please tell me what's happening in your offices. Please tell me what's successes, the challenges, the barriers. So a big shout out to everyone who took time from their busy day to let me know. Okay, so we're going to go to, all right, so we're in the next slide already, perfect. Okay, so in general, our colleagues have similar tactics. We're all doing the same thing. There's lots of writing in there. I'm encouraging everyone right off the bat to share what they're doing. The chat's been very, very active. So for the most part, I know in our office and in many other offices, we are respecting IPAC. So that means we are taking universal precautions, full PPE, gowning, masks, shields, and gloves, especially when we're seeing the sick patients. We are treating COVID and influenza, any of the ILIs, as the same thing. We're not making any differentiation. The focus is on seeing kids, at least actually in my office and all the other offices, because we know that these kids can get really sick. Parents have little tolerance for sitting next to many, many other people for hours in the waiting room. We are social distancing. And so there's some really creative solutions that have been put forth. Parking lot, if you have access to the parking lot, examine your patients there or have them wait there until it's their turn. Having a sick room that's close to the entrance. So if you have a room, you check in and you just go quickly there, you're not going to have them spreading all their germs theoretically. We're trying to get access, same-day access. Triaging on the phone is really helpful. Some of the offices are requiring patients to do rat tests before they want a negative rat test, and physically separating the sick from the well. So really, I think all of these strategies work if you have the space, and you have to tailor it to what's happening, how your office setup is. And I actually have some people saying, you know what, just bring people in. Bring them at the end of the day if we can, just bring them in, because patients are getting anxious. Okay, next slide, please. All right, what does Clint Eastwood have to do in a medical talk? Well, first of all, I love Clint Eastwood. All of his movies I find are really hopeful, and he ends up overcoming all the odds and he's victorious. So, I thought let's apply that sort of thinking here. And considering the circumstances that we're currently in and going into, I thought the title of The Good, the Bad, and the Ugly was appropriate. This movie was released in 1966. It celebrated a 50th anniversary, so it still has some enduring qualities. Next slide, please. So what's happening out there that I think are the strengths or the good? And this has been actually identified several times over from my colleagues. We have vaccines. We have boosters. We're able to protect ourselves. We're able to protect our staffs and our family. So vaccines are a good thing. We didn't have that, at the beginning of the outbreak. Our rapid antigen test and PPE stock, lots of it. Yes, I know we're paying for it, but at least we have it to protect ourselves and protect our staff. There are more treatment options out there, and Janine alluded to all of that, so I won't repeat it here. We have virtual medicine codes, and I know some people are going to post in the chat, yes, but the virtual medicine codes are being decimated. We still have them, so I think let's make use of them. And the other strength is our knowledge of COVID keeps on increasing. So we know more about this previously unknown entity. The next slide, please. Okay, so the bad. Well, these are weaknesses to the system that we are all experiencing. Patient anxiety is at an all-time high. Parental anxiety as an all-time high, which really behooves us to try and address the kitty issues before they end up in emerge. You know what, honestly, patients are just tired of masking. They're tired of vaccines. They're COVID tired. And that makes a challenge for us because if they're not masking, there's going to be an increased demand for services, our services. And then on top of that, the ministry has said, hey, guess what? We're in post-COVID recovery. So you need to catch up on your PAPs, your mammals, your preventions, your diabetics. So that's adding pressures from other parts to our system. And honestly, I need to touch on this. We're getting a little bit frustrated, burnt out, weary. But I think we need to acknowledge all of these things. Next slide, please. Okay, so the ugly, and what I mean by this is external pressures that we really don't have control over. I think we're going into a new wave. Dr. McCready alluded to this. It's going to be a difficult and a long cold and flu season. We are already running out of medication. Our patients are saying, look, I can't get acetaminophen, I can't get ibuprofen for my kids. What do I do? I need to help with that. I try to support them through that. And the adults, there's no cough and cold medication on the shelves. And then the unknown of the new variants, we don't know. But I think if we acknowledge these things and say, okay, this is beyond our control, it is helpful. Okay, next slide, please. So finally, what are the opportunities that are presenting themselves? Well, I think, unfortunately or fortunately, we need to acknowledge that we have to focus on patient re-education. Taking that extra minute to say, you know what, a cough that's developed within the last hour, can't tell you what it is, but these are the red flags, and these are when you need to call me next time. And hopefully by educating them, the next cold they get, they'll wait a few more days. I truly believe as family physicians, we need to support our patients through their anxiety. If they feel heard, they're going to be less anxious. They'll listen to our education piece. Hopefully it'll help for next time. I would love our goal to keep patients out of the emerge. And so at the time of this, I'm thinking, if we have, let me see how many participants we have. We have about 640 participants. So if each one of us was to keep one person out of the emerge, that's about 640 patients that we're keeping away from the emerge. That's a little ask, one patient. We need to continue to respect IPAC. And I would like us to remember that lots of resources out there. I am referring everyone back to the antimicrobial stewardship program that was developed by Dr. McIsaac. The link is posted on the slide. There's some really good basic stuff on how to talk to patients, how to differentiate, how to not overprescribe. I think we need to continue to remind ourselves of this. VaxFacts, it will be posted later. That's also a good resource. We can refer our patients who are hesitant, who are anxious, to have some time with the physicians. VaxFacts does not eat into our outside use. So that's something we may want to avail ourselves to. My wish list, well, we need a public campaign. It's great to say, hey, doctors do this and that, but the other half of the equation is our patients. And so if we can have a patient education, this is a cold, they forgot how it's like to be sick, they're anxious. And I would love funding support for the extra expensive PPE. We're all small businesses and we're all struggling. And really, yeah, that's my talk. So I hope it's been helpful. We're all in this together. We're trying to support each other. And just remember, if we can deal with one patient to keep them out of emerge, that really will go a long way. Thank you so much.
Thanks so much, Rosemarie. Much appreciated. I mean, I think your presentation really resonated with a lot of colleagues. There were some really good comments in the chat to say, that the ugly includes also lower pay, higher costs, more paperwork, that really it's not the cold and flu staff that's getting them, it's the mental health, complex medical conditions and not being able to get help, time spent refaxing referrals that are rejected, and the public health not reinstituting mask mandates. So, I think there's so much that you said that I think was really resonating for our colleagues. I'm going to turn it to you, Mekalai. If you could just speak to some of these resources that I think the OCFP is highlighting as ones that might be helpful to physicians. And again, I just want to highlight too the terrific OMA resources that Natalie and her team have posted in the chat. Mekalai?
Thank you. Yeah, it is a very challenging time. And I think our goal at the OCFP is to try to provide you with resources that will help you to streamline some of the processes in your office, recognizing that we are seeing very high volumes of respiratory infections. So I'll just quickly touch on some of the resources that we have available. So we have pulled together a script that can be used either via email or to mail to your patients to provide an update on flu vaccines, COVID vaccines, and when to seek care. We have an updated IPAC summary for community practices that will hopefully be useful in terms of recognizing how to manage some of the IPAC procedures in smaller offices. We also have a document on just managing respiratory symptoms in office, knowing that we are seeing a whole range of viruses. I'll just highlight that the Confused About COVID series has updated the My Child Has COVID, so that is one to look for. And this may evolve over time, recognizing that we are seeing such a range of viruses at this point. And then finally, there's a Q&A on IPAC and PPE for primary care.
Thanks. Well, just with the next slide, I just wanted to highlight a resource that Rosemarie spoke about. So this is from Latif Mourji and his team at the VaxFax clinic in Scarborough. We do really need to support more of our patients to get vaccinated, and they have now expanded their offerings. They may be expanding their offerings and branching out further than from COVID vaccinations. I think they are doing some more preventive health counseling, but please do think of them as a resource for folks who are needing a bit more time. I wonder, I know we were going to stop at 9, and I wonder, Janine, are you okay to go for another 10 minutes just to answer a few more questions, because there are a lot of questions in the Q&A still that we didn't get to, a couple of which I think are quite important.
I should be good. My clinic hasn't called me yet. So
okay, great. So so maybe we'll just stop slides there, Olivia, and I'm just going to ask Janine a few more questions. I think one, to just building on that VaxFax poster, one thing that's come up quite a bit in the Q&A in various formats is how we counsel effectively for COVID vaccines for those under 5. This is in relation to the NACI guidance that is saying may as opposed to should. And I think, Doris Lee says there's data regarding immunizing children under 5 regarding questionable effectiveness. So I think that this is, some of the messaging that is out there, and I wonder what you would recommend that we do to kind of increase vaccination and how we counsel about that.
Yeah, I think this is, it's a huge challenge and not easy given all the different information out there and how everything's presented. I think the things that as an infectious disease doctor and a parent that I think about is that, we vaccinate children for many things that prior to when we had vaccinations for, there were far fewer hospitalizations from those infections than we see from COVID. And we are still seeing children, especially under 5, that are unvaccinated, getting admitted to hospital for COVID. And even if we know the vaccine's not perfect and it's not going to prevent them from getting infection entirely, but based on, all of the evidence we have from the older age groups, we know that it does something to prevent severe disease. And the challenge is we don't have studies of that 2 to 5 group in preventing, MIS-C or hospitalizations, because you need such huge numbers. But logically, and understanding what we do about the vaccines, that providing your child with a vaccine and and introducing their immune system to it, in almost all cases, it should reduce that risk of severe disease. So even if that risk is low and it's just reducing it by a little bit, it is still important to do that. And when you look at I think the important thing is looking at risk benefit. So the risk to them of the vaccine is exceedingly low. They might have a bit of a sore arm. There's almost no serious side effects from that vaccine, versus the possibility that they might get this and get admitted, or get it and pass it on to their younger sibling who's a baby. All those things, I think it does on balance. It's all, everything's risks and benefits. So on balance, I think that there is a benefit to it. And as an ID physician, all my friends and family that I have that have children under 5 in that age group, they've all had the COVID vaccine. And I've told them, unanimously, please get the vaccine. We vaccinate against rotavirus and all these other things that we did see children probably get admitted at the same tempo as we're seeing with COVID. And it was, I think it's just because there's so much information out there with COVID that it makes it more challenging. And I'm not going to, overrule NACI and say should instead of may. Obviously, I don't have the authority to do that. But I think NACI is very cognizant of, everything out there, and also that, we don't want to put pressure parents. It's more of that collaborative conversation. And so the may is more, to have engage them and have that conversation, as opposed to it's not going to be, they don't want it to be added to the mandatory list of vaccines. And I don't think anyone wants that either. But I think looking at the balance, if there's anything we can do to prevent these little people from getting admitted to hospital, I think that it's worthwhile doing, and with really it's besides just the pain of the shot. So I think it's there's not really a question in my mind that I think it's useful, and I would recommend it to my patients and my friends and family.
Thanks so much, Janine. So a couple more questions. So one question is about COVID positive healthcare workers. So how long should COVID positive healthcare workers and staff in our offices be isolating from work?
Yeah, so I mean, this is a tough one. People, I think it depends on your setup and what you can do. And we're in a we're in a human resources, total chaos, collapse, crisis. So people are still infectious from COVID, likely for 8 to 9 days. That hasn't changed. COVID hasn't somehow, gotten magically shorter in terms of infectivity. But we know there's things we can do to minimize that transmission to other people. And I think it's that risk benefit. So do you have someone that can work from home that's not impairing the function of your clinic or, your ability to take care of people, then it ideally, work from home or work remotely or work, more in your office, not in a common area, for 8 to 9 days or 10 days, that ideally. So have somebody, instead of them being the person sitting in a room with 5 other people, if you can put them in a different space, ideally. But if you don't have an option and no one's there to see it, then I would say, ideally at least 5 days. And then at that point, come back to work if you're feeling better. Some people aren't feeling better, but if you're feeling better, wearing fit tested N95 and not being around anyone without your mask on, basically. So, I mean, from a hospital standpoint, a lot of us have had to move to this because we haven't had enough staff. So it slowly creeped down. It was 7 days with 2 negative rats at 6 and 7, and then you could return, but almost no one is rat negative at that point. So I would say minimum 5 days. If you do come back at that point, have your N95, no unmasked time. So if you're eating, you got to eat outside or eat in a room by yourself, and always have your PPE on. And if you have your N95 on and everyone around you has your masks on, the chance that you're going to transmit is very low at that point. And I think that's the best we can do at this point. None of this is ideal, but this is the reality of what we're going to be facing this winter.
Thanks, Janine. I will say, Rosemary, you're still getting lots of shout outs in the chat about how pragmatic and positive, and also just I think how people, it really resonated, the messages that you provided. So thank you. I'm going to turn it to Kim Ireland's question, Janine, which was, can you comment on single dose dexamethasone for RSV? How can you best prescribe it in a walk-in clinic type of setting?
Is that for me?
Yes, that was for you.
So I don't usually see little kids that need that. So I don't know if anyone else, I don't know if Dr. Lall or someone else, because they call me and I say, this sounds like a good idea, but I don't actually, I'm not the one doing it. So that's probably, I don't know if anyone else wants to help with that one.
So I can say that we see that in Emerge when our little kiddos get there, instead of coming to us, that's what they do. You know, if you're comfortable that this is what they have and they have that cough and they have that look, one dose and then follow up the next day. And the dosing, don't ask me what it is. I always look at every single time just to make sure I don't make an error. So I've done it in the clinic. My colleagues have done it as well. Thank you.
Thank you. So Janine, I will say that there have been a couple of colleagues of mine who've texted me directly, or I think even put in the chat that they're not sure about this evidence base of using Tamiflu in primary care, and so there were just I just wondered if you wanted to address that head on, because I think we also don't want is just over prescribing of a drug that may not be helpful. Yeah.
Yeah, I know. I mean, it's a good point. I think the trouble with Tamiflu, perhaps I was a little bit more ambitious about the use of it. I think as I was going through this and then I reflected on it after, I think of strategies that you can use to minimize people kind of ending up in hospital. And I think Tamiflu is a tool, but thinking about the scope of the people you guys see, it's probably very few that would actually benefit from that. So it's tough. I mean, the people that I would consider, like if we see someone in the emergency department, or we're seeing someone in our, ILL assessment clinic that has flu, the people that I would consider treating it would be the kind of the highest risk people. So if you have someone where you think if the wind blows, they'd end up in hospital, and you think they have influenza, they're negative for COVID, maybe those are the people that you may consider prescribing for it, if you can get them early enough. I think the challenge for most of you is that you're not going to see them, within 48 hours, or be able to get an answer within 48 hours. So then it becomes pretty much useless. So I wouldn't prescribe after that point. And I think overprescribing, we don't want to be doing that. Tamiflu is pretty benign, but it can cause GI side effects for sure. So, I mean, I think it's a tool that I think we need to figure out how to use it better, and who would be the people that would kind of benefit the most from that. So if you have an person that's unvaccinated for flu, they're in their 80s, multiple comorbidities, and there's lots of flu around. It looks, smells like flu, you think it's flu, maybe that would, and you get them on day 1 or day 2, maybe that would be someone you could consider using it. But I mean, you're right, I was probably a little overzealous, thinking more about the people that we see coming in and who I would prescribe it to, and then trying to extrapolate that to, well, who could we prevent? I think all of us in hospital are thinking, well, how can we prevent people from ending up in here? And I think that, I mean, you're right, the evidence for Tamiflu, you'd have to treat a lot of patients to prevent an admission. So really narrowing in on who the absolute highest risk people, and who can you feasibly treat within that 48-hour window. So does that help?
Yeah, I think that's helpful. I think just to temper, to let folks know, this is not a magic bullet here. I think one of the things that's always been a struggle when we see patients with cold and flu is that we have a number of things we can recommend to them. Mostly we're reassuring them that they will get better with time for the vast majority that we're seeing. So just a couple of things. Two topics, and then we're going to end. One is just the risk of myocarditis with the COVID vaccination in teens, young adults. Does that influence so what is the current data on that? And I don't think when you talked about the bivalent booster, whether that influences your choice, and I wonder if you could speak to that too.
Yeah, so from, I had a scope in the last few weeks to see what's new out there, but the last time I looked at things, it was actually encouraging that most of the cases of myocarditis, it was lower with your third dose than it had been with after first or second. So it seems like if you didn't have myocarditis with first or second dose in that age group, it was less likely to get it with subsequent doses. In that, kind of most of the myocarditis cases we're seeing, they're not in the younger kids, so not in under 12. It's more in that kind of 15 to 24, more in males. Would be the highest risk category. And I mean, for those individuals, if them, I would certainly wait a longer interval. So I wouldn't, reboost them at 3 months unless they're significantly immunocompromised. Them, I would wait at least 6 months from last COVID infection or last booster, and potentially even longer, because they're young, they're healthy. The likelihood that they're going to get severe disease is exceedingly low. And then in terms of which dose, so say they've only had 2 doses of COVID vaccine and they never, they didn't get their third dose, they had COVID last January, then, it would be reasonable to give them a bivalent vaccine. And between the two, I would go on with Pfizer in them, just because it's a little bit lower dose of the mRNA.
Thanks, Janine. So the last set of questions actually relates to Paxlovid. And I think this relates to the fact that, the guidance from the science table, which is now disbanded, is older. So are there new guidance for that? Of course, there it said it was, and I think you spoke a little bit to that, because Patricia Lee was saying, it says that 2 to 3 vaccines more than 6 months ago would be, they had a certain high risk criteria. You said that, now we need to rethink that. And then I think there's some questions around, do we monitor just for a few days and at day 4 or 5, they're still not better? Do we treat? So I think you answered some of this already, to be honest, and some of when you talked about it, but maybe you could just re-review some of the key messages on Paxlovid. And I just wanted to say for the audience that we are likely going to bring this back as a topic on our COVID community practice as a focus, because I think there's probably a lot to discuss, including, I think, a new opportunity to participate in a trial that will help us to understand the effectiveness of Paxlovid in a wider array of people. So over to you, Janine, to just give us some key messages on Paxlovid.
Yeah, I mean, I think the challenge is, again, there's kind of a paucity of evidence in the vaccinated population. And as we get further out from when people are dosed, they're also, how do we incorporate that in our risk assessment? And I think that's the challenge, and exactly how you said. And I know when we're seeing people in hospital or in our clinic, when we're deciding whether or not to prescribe Paxlovid, it's using those factors. So I use the rough science table matrix, but then you're also kind of looking at the timeline. I kind of add in time from last vaccine as another factor. So number of vaccines and last infection is important. And then, comorbidities is obviously important. So if they've had 3 doses of vaccine, the last dose was in January, and they're over 80 and they have 3 comorbidities or 2 comorbidities, then I would have a discussion with those people and offer them Paxlovid, versus, if they're a healthy 71-year-old with no other medical comorbidities and their last dose was last January and they just have very mild symptoms, those people I probably would say, okay, let's see how you're feeling in a day or so, unless they're super keen to take it, right? Some people they come in and they're like, I want Paxlovid. And then in that case, I tell them about the side effects. They'll tell them if they start feeling terrible, they can stop from the Paxlovid, they can stop taking it. But those people, be willing to give it. If someone's on the fence and they really are looking to you to say, like, what should we do? Then it's really that, that risk assessment. And do you think the benefit of the Paxlovid is going to be less than the risk? And so I think in most cases, if you're almost a year or 11 months out from your last vaccine and you have, any medical issues and you're over 70 and you don't have significant interactions that are going to put you at risk from the medication, then there's probably like, again, that risk benefit. So there's probably more benefit than risk to taking it. So I would prescribe in those cases. But again, having that conversation, if they start getting terrible diarrhea with it, then, maybe time to reassess and stop. They don't end up in hospital with their terrible diarrhea. And if they tolerate it well, then great. So it's hard to put it's just an easy answer on it. It's a discussion with the patient, depending on their risk factors. Again, if they're immunocompromised, I would err on the side of treating it, because then those vaccines are, they don't have that immunity, and you want to get to those people early.
Thanks. Thanks so much, Janine. So I wonder, Olivia, if you can put up the second last slide. And so thank you to everybody for all of the Q&A and a lot of the amazing resources you guys have been putting in the chat. I did want to say that, we're continuing to plan these sessions out. It's clear that they're popular still and meeting a need. And we want to hear from you. Are you interested in helping being part of this planning team? We want to have content that is relevant to people from a wide variety of practice settings across the province. And we're looking to supplement our current team with other perspectives to support us to continue to deliver content that is relevant and helpful to family physicians broadly. So if you're interested in joining our COVID community of practice team, can you please let us know? You can email us at ocfpcme@ocfp.on.ca. And then I also wanted to say, you can always inform our next session also by clicking on the evaluation link. So we'll go to the next slide. And our next session is in a couple of weeks on November 11th. And we do send out an evaluation just at the end of this session, but part of the evaluation is always what topics you want to have covered. I see a few suggestions from in today's Q&A and chat, but if you have others, we definitely want to hear them. And always these sessions are designed around your needs. So the more you're able to tell us what's helpful to you, the more we can actually work to meet those needs. I want to end by just giving a huge thank you to our panelists, Rosemarie Lall and Janine McCready, who have spent time preparing for the session and attending today and answering all of your questions in this very continuing to be difficult time. I think we had hoped that we would be past difficult times at this point. Thanks to my co-hosts, Mekalai, Kumanan, and Liz Muggah, and our supports team. And thanks to all of you who are continuing to do the really hard work of caring for people on a daily basis. So thank you, and we'll see you again in a couple of weeks. Take care.